Now, I'd like to invite my co-chair to the podium, and we're very lucky to have such an experienced cardiologist from São Paulo in Brazil. He used to be the president of the Cardiologist Society in Brazil, so could I ask Professor Feitosa to present to us, Gilson, if you could present to us your view from a cardiologist's perspective. Thank you.
Mr. Chairman, thank you, ladies and gentlemen. So I'm asked to give you the heart failure management, a cardiologist's view. In order to do that, let us take a look at what was seen in this study, the optimized heart failure study. They did a performance measure of over 5,000 patients with heart failure, evaluated in 91 hospitals in the United States. And this performance measure was to see what was the survival and what was the hospitalization seen in these patients in a period of 60 and 90 days. Let's see what was seen. The best elements for this performance measure were the prescription of ACE inhibitor and beta blocker upon discharge. So these were the variables that influenced the mortality and the mortality or re-hospitalization. Beta blockers did both, and ACE inhibitors, they did not influence that much mortality in this study, but diminished the re-hospitalization. So if this is the performance measure, the most important ones, how are we doing with it? How are cardiologists doing? Let's take a look at this study. And this try to evaluate this, the cardiologist's performance, as compared to the primary care physician performance. And what was seen was that those variables, as well as many other measures that provide good care, guideline demonstrated evidence for good care in heart failure, were much better done by cardiologists than by primary physicians. So my first conclusion is, if one has to have a good care for heart failure, the best way is to have a cardiologist dealing with heart failure patients. That's the first conclusion. But how are cardiologists doing now that, if that's so, how are they doing, how is their performance? Let us take a look at some of the late studies that are dedicated to patients with severe heart failure. Let's take one from 2005, and I'm talking about CARE heart failure study. Those were patients with the New York Heart Association functional class 3 or 4, so very severe heart failure, and they were evaluated for pacemaker resynchronization. That's not what we're going to discuss here. What I'm trying to take a look at is what was their medication delivery for these patients. And as we can see, it was very good. So that beta blockers were utilized in something like, we're talking about 2005, 74% of the cases. ACE inhibitors were, angiotensin receptor blocker were utilized in 95% of the cases. And therefore, this performance measure was well accomplished in patients inside this trial, the CARE heart failure trial. Well, let's see something more recent. Let's see the MADE-IT CRT trial, 2009. And what was the performance measure for these patients now with less severe heart failure, because the heart failure was 1-2. And again, the performance was very good. As you can see, angiotensin inhibitors, angiotensin converting enzyme inhibitors, 70%. If we add that to the angiotensin receptor blocker, 20%, 97% of the individuals were utilizing some way of attenuating the renin-angiotensin system. So very good. The beta blockers, 93%, as we can see here. This is in trials. Trials represent a relatively artificial world. In trials, everything is well controlled, and many patients are not included in trials. So for us, it's very interesting to take a look at the real world. In order to do that, let's see, we just concluded the Brazilian registry of acute heart failure. That's called BREATHE registry. And in our experience in Brazil, how well are we doing? 2014, the application of this performance measure in our patients with heart failure. Well, this is what they were utilizing in the hospital or when they were discharged. And as we can see here, we applied renin-angiotensin system attenuation, that is ACE inhibitor or ARA, in something like 65% of the cases. This plus this. And beta blockers in 57%, so quite different from what we see in the trials. Now, how about the European experience? That's how it comes. This is the only one attempt of doing a survey in heart failure in Europe. This was done in teaching hospitals, basically in teaching hospitals. And ACE inhibitors and angiotensin II receptor antagonists were utilized in 65% of the cases, not 100%, 65% of the cases. Beta blockers, something around 40% of the case. This is the real world, not the world of trials. That's the one we should pay attention more closely. And what could we do in order to improve this? Certainly, we should structure our heart failure care program. That's what Dr. Fonarov did some years ago. And as you can see in the left, that was the readmission rate that was seen with his patients, and that's in the solid black, before the implantation of a heart failure clinic. To the right, you'll see what it became when he started doing a structured care of heart failure patients. So it made a lot of a difference. So this signals the way for us to do good care of patients. It has to be with cardiologists, and it has to be in a very structured way in order to benefit to the most our patients. That's because the heart failure patient is not only a patient in whom the heart fails. There are many problems associated with heart failure patients, and they have to be taken care carefully. They will imply a lot in the final results of our treatment. So when we see in the real world that only 60% of the people taking, for instance, beta blockers, it's not necessarily because the doctors don't know that they have to utilize beta blockers. There are many circumstances in which beta blockers are not used fully or even initiated because of previous contraindications for its use. In my area, I mentioned to you yesterday, we have Chagas disease. Our rate of utilization of beta blocker in Chagas disease is something like 40%, because they have heart blocks as one of their manifestations. They have bradycardia, they have sinus node syndrome, and so forth. So even if we wanted to, we will not have the possibility of giving beta blockers to all of the patients. So this is real world. There's a lot of comorbidities that will affect the way we deal with patients with heart failure. That's why we have the need not only of the cardiologists, but we have a need of a team, and this team is comprised of many players, as I will show to you in a few minutes. In the United States, the core cardiology training, the COCATs, They suggest that a cardiologist, to be able to deal with, specifically with heart failure, he should have his usual training, which is to complete a 3-year cardiovascular fellowship to establish board eligibility in the medical specialty of cardiovascular disease. This is the minimum for a clinical cardiologist. To be a heart failure specialist, he should have at least 1-year fellowship in advanced heart failure and transplant. That's the minimum for him to be to say that he is a heart failure specialist. So we had this idea that I'm going to submit to you. If we think about the heart failure clinic, we can think of distinct domains, and we could grade them. And with this, we could set our way in order to improve our own performance. Let's consider first the available treatment. Certainly, it's different if one has only the clinical cardiologist, dealing with patients. Better if he has a clinical and a surgical team in the same environment. Even better if he is capable of having circulatory support. Even better if he has all of this plus the ability to perform a cardiac transplant. This is the first domain, as I suggest. How about medical research to establish a heart failure clinic? Well, the minimum would be to have a general practitioner or an internist. Better yet if he has a cardiologist, but even better if it's a well-trained cardiologist in heart failure. Let's go on. And let's see what's the need for a multi-professional involvement. Well, if there is none, he could be a single cardiologist, and he does a little bit. But he does better if he has a surgeon discussing with him. Even better if he has a nurse, dedicated nurse to the subject, a physiotherapist, a nutritionist, a psychologist. So how about monitoring and education? If none is done, well, he could call it a heart failure clinic, but better if he has a well-established educational program, if he has an outpatient monitoring, if he has a telemonitoring. And as it was very interestingly shown to us by our co-chair, better yet if there is a program of house visits. This is the maximum, probably, in care of monitoring and education. And finally, how about structure? Well, it could be the patients could be seen in any place. This is the general. Or they could have a special structured ward that's dedicated to cardiac patients. A little better. Better yet, if he has in the hospital a specialized outpatient clinic for heart failure. And the best of the words is when he has a clinic, a ward, that's specialized in heart failure care. So I think we could envision something like this. One could have a simple situation of being a physician, an internist, alone, with just delivering the care and doing his best to deal with the patient, and in a general situation. He does something. It's better this than nothing. But better yet would be if he had a very, very well-established cardiac program transplant, if he has a heart failure cardiologist, if he has many people helping him, and the nurse is fundamental for this care, if he has a system of education, especially with telemonitoring, even better if there is a house visit program, and if his hospital provides a way, an intensive care unit dedicated to patients with heart failure. That's the ideal world. Well, we can look at this and see where we are in our service. And if we are not accomplishing all of this, we should, little by little, do an effort in order to probably to get there, in order to have the best service available to treat patients with heart failure. Let's see some of the results. Our chairman did a great job showing the latest information regarding this subject. But let me point out some specific studies that are close to us. For instance, this study was done in Brazil. That's the REMADE study. It was a simply structured to have a meeting with all the patients with heart failure, giving education. There was an initial contact, and afterwards, everybody gathered together and received consistently education. The other group, which was randomized for the usual care, had worse results regarding hospitalization. Let's see this from Argentina. This is a well-known study, which is called DIAL. In this study, nurses called upon the patients in day 1, 2, 3, 4, and afterwards weekly, in order to monitor weight, in order to monitor medications that were being given, and stimulating the patients to the diet, and especially to the weight measurement and the instruction thereof. The result was a significant reduction in hospital readmission, so it works. This is another study in which multidisciplinary intervention to prevent readmission of patients with heart failure from the Washington University was tested. The results were positive. This is another one in which elderly patients now, had home visits by nurses. The results were much better. In conclusion, ladies and gentlemen, I would say that a cardiologist offers a better care for heart failure patients. Even better if he is trained in the field of heart failure. But the best of the world for the patient with heart failure is when he had a severe case of heart failure, is from that point on to be involved in a structured, multi-professional care because this gives the best results. I thank you for your attention.
Thank you, Gilson. I think it's extremely important we have a cardiologist viewpoint here and support, because I think without that, these programs don't exist. So they have to come from the leadership of the cardiology. So do we have any questions from the floor? Kazim, if you...
Thank you so much, Gilson. Great. I just want to mention to you, if you go to our website, actually our society and our founder of the society and the immediate past president, Professor Remy, we were able, Heart Failure Society, and we have fellowship programs, 6 months or 1 year, and we have sent doctors from Kenya, from Tanzania, and they were in South Africa, yes. And Professor Simon, he played a great role in that. So that's the trend, as he said, we want to encourage it, and we hope we will have fellows. The only condition, the heart failure support you go there, you stay 1 year, but in condition when you come back home, you work 2 years to help your own country and people, and after that you are a free woman or a free man. Thank you.
Thank you for the presentations. From the practical point of view, how many patients, heart failure patients, could a nurse cover? Because when you want to start a program like this, you have to know how many personnel you have to hire to get a clinic going. Let's say if I've got 100 heart failure patients, how many nurses should I have?
Okay, Gilson, do you want me to answer that, or you'd like to answer that?
No, I can give you my experience. We do have a heart failure clinic, and it doesn't take too many nurses to take care of. We have in our heart failure clinic, we have 2 dedicated nurses to cover the whole ambulatory, and they make a telephone call. We do not have yet an established home care program.
So I would just, if I can just answer that we have 100 to 150 active cases per nurse, but you do need a discharge program. In other words, one of the issues with the heart failure management programs, if you provide the same level of care, it's unsustainable. So you do need to actually have a sort of a lower of monitoring. But we do have a question at the back there, or comment?
Thank you for your excellent presentation. Just a comment regarding the classification of the heart failure team. It's the electrophysiology. The electrophysiologist, I think it is one of the important component of this team, especially patients who are refractory to medical therapy that will require cardiac resynchronization therapy or implantable defibrillator, which is, one of the life-saving proven, and it has impact on mortality. The other thing is pharmacist. I have not seen it. I think it is also an important part. Your comment on those.
Yeah.
Thank you.
Well, thank you. I could not agree more with you. For the resynchronization to be considered, the cardiologist has to consult the electrophysiologist. Part of the training of a heart failure cardiologist trainee is to be very much aware of this, is to be very much aware of the 150 milliseconds QRS with the left bundle block pattern, is to be aware of the asynchronism demonstrated by echocardiography, to rely well enough in the QRS, and so forth and so forth. But it's part of the training of the heart failure cardiologists to be very much aware of the new developments regarding this kind of support. And that's how the electrophysiologist is called upon.
We'd have one more question, if we could just on the floor.
Okay,
One
thank
more
you
question.
for this very interesting topic. I'm asking about the authorization for the nurses to prescribe medication. Are they authorized to change drugs or to add a drug if the patient feeling more deterioration?
Yeah. Well, usually the hospitalization comes from the patient's symptoms. If the symptoms are relatively less intense and they are resolved with one single shot of furosemide, usually this patient, that's well known, it has no acute coronary syndrome, that is enough in order to send him home. If this does not solve his problem, that's when he is admitted. One of the first reasons then is one of the characteristics for the admitted patients is the intensity of the symptoms. And when the symptoms are less intense, if they are solved with, let's say, a loop diuretic, they could be handled at home, usually.
So on that note, we'd like to thank all our speakers for a fantastic session. Thank you so much, and we'd like to present you a present for speaking with us, and your present, so please. Thank you.